Hi everyone, and welcome to the latest in our series of video interviews. Now today we're talking about concussion and brain trauma, which has been in sports news recently. You might have seen with quite a few reports about head injury causing early onset dementia and other long-term conditions. So we're joined by Professor Hugh Williams, Associate Professor of Clinical Neuropsychology and Co-Director of the Centre for Clinical Neuropsychology Research here at Exeter, and Dr. Adam Reuben, who's a consultant emergency physician at the Royal Devon and Exeter Hospital, and also the club doctor for the Exeter Chiefs Rugby Club. So welcome both of you. Thanks for joining me.
Thank you.
Thank you for having me.
Now, if I could start with a relatively simple question, hopefully. Could you describe for a non-medical audience what actually is a concussion?
I think actually that's perhaps not as straightforward a question as you might think actually, because the diagnosis can cause some controversy. But essentially, concussion refers to the constellation of symptoms that you experience after a bang on the head, or as we refer to in medical circles, a mild traumatic brain injury. And so typically that will be symptoms after a blow to a head, but that's not necessarily the case. So concussion can be caused from a significant blow to the body, particularly in rugby, where you get force transmitted upward towards the head. And the symptoms of concussion are going to be things like headache and dizziness, but can include things like confusion or irritability or low mood. People suffer with poor concentration. They describe feeling in a fog. And these symptoms can come on immediately, or they can come on after delay, and that delay might be hours or sometimes days or sometimes even more. And one of the key features of concussion is it's characterized by a lack of any abnormality on the traditional imaging modalities. So if you were to do something like a CT scan or an MRI scan, you'd expect them to be normal in the case of concussion. But if you were to look at a cellular level, say with an electron microscope, you might see evidence of micro trauma of that level. And I guess the final thing for me to say is that a common misconception is that you need to be knocked out to sustain a concussion. And in fact, anecdotally, in rugby, certainly some individuals who are knocked out, that episode actually seems to be protective, and they suffer less concussion than those who suffer blows to the head where they're not knocked out. Concussion, certainly rugby, seems to be most frequently associated with blows where players are knocked out.
Okay, cool. Now, you just mentioned sometimes you can't, there are no real symptoms for any length of time, or it won't show up on things like a CT CAT scan. So if you're in a sports match and somebody gets a blow to the head, there can be quite a lot of blows to the head in rugby or football, hitting the ball, that kind of thing. How do you identify a concussion versus something which is perfectly okay?
So it's really it's not so much about identifying concussion in a rugby match. It's about identifying mechanisms that might be compatible with concussion, if that makes sense.
Okay.
Having said that, concussion doesn't predominantly follow loss of consciousness. Certainly something. Apologies for the noise in the background. The dogs are going wild. Concussion doesn't always follow loss of consciousness. Seeing a player knocked out is clearly something you can look out for, and players can suffer concussive symptoms afterwards. So that's one thing to look out for. If somebody's knocked out, that's fairly easy to say that player might subsequently develop concussion. Therefore, they're going to either probably be removed from the field of play permanently, or certainly have an off-field assessment. But really, in terms of rugby, you're looking at two things. You're looking at a mechanism where that might be compatible with the subsequent development of concussion. So we've talked about these collisions already. So impacts primarily to the head, but sometimes to the body. But probably more importantly, from a medical perspective, what I'm looking for is how a player reacts to that collision. So what happens after that impact? So are they lying still on the ground for a sustained period, but without loss of consciousness? What are they like when they stand up? Are they ataxic? So do they stumble and find it difficult to keep their feet? They might have abnormal posturing, so they might become stiff in the arms or legs before they lose tone, or they might even have a seizure. So it's really about watching for some subtle signs that might indicate a mechanism whereby they will subsequently develop concussive symptoms. I guess the challenge we have nowadays with modern rugby is that players are probably 2 or 3 times bigger than they were 20 or 30 years ago. So if you have two big players running at each other, you could argue that every collision is compatible with concussion. So you do have to be pragmatic, whilst obviously being safe at the same time. As a pitch side medic, if I were to remove players from the field of play, every time they tackle something big, I probably wouldn't last my job particularly long.
Yeah, that's really interesting, Adam, about how you are looking for the kind of behaviours that could make going along with a concussion, and it's in some way, and often it's very hard to spot, isn't it? So sometimes there's a need for a spotter, to just check all the videos and everything at the professional level. At the amateur and school level, there's probably not very much systems in place to be able to really kind of notice what's happening. And most concussions in rugby are happening at the amateur and school level. You've got about 3 or 4 times as many concussions happening in that context. So it's actually quite vital for people to get an idea of what the kind of thoughts that someone like Adam is having from a point of view of, I think a concussion's happened here. So because the best thing to do is to take the person off and not let them play on. The rest of obviously the head injury assessments, HTA, the assessment that to check on whether a concussion has happened. So Adam is looking for, are there the signs that concussion happened? Oh yes, there is, and then you're checking the person out to make sure it has happened or not, and then the person's off. And in rugby, it's been quite good at bringing that in, so that you can have a substitute on for the assessment to continue. And then the person's taken off or put back on again. And football is looking into that as a possible mechanism as well. But I guess one of the main points is that, well, what happens, we need to get good practice from the kind of professional level in rugby, as Adam represents, into other level as well. Because the risk of not picking up concussion in a match is that you have another concussion. You're more likely to have another concussion if you had one, because you might be more unsteady on your feet, not very good at understanding what's going on, and you may take a very risky kind of position. And another concussion could be more catastrophic because you have something we call second impact syndrome. And we're not quite sure what the mechanisms are there, but the brain's more likely to respond negatively to a second one before the first one is resolved. So that's important.
Okay, so what could happen if people were to continue playing with a concussion? I mean, one of the reports people would have seen was Jan Vertonghen, who's was a Premiership football player. He suffered a head injury, carried on playing for something like 8 or 9 months, and it wasn't until lockdown, when he was forced to stop, that he realised, that there'd been a problem that whole time. I mean, what can happen in those kind of cases?
So I think there's 2 aspects to that. I think Hughes covered off the first and most important one from the outset, and that is the risk of a further head injury in the acute setting, and you can get this very rare but quite deadly condition known as second impact syndrome, which we don't see much of. We don't really understand it, but that is the risk, and that's why we're so attuned to picking up those initial concussions. But it's really more what happens afterwards, and we don't really know from a brain perspective what those risks are, and I think more evidence is emerging. Interestingly, we do know that there's very good evidence that players who come back from concussion are at significant risk of a further non-concussive injury. So there's up to twice as many musculoskeletal injuries reported in some studies in the first 12 months after concussion in those concussed players versus the non-concussed players. So players come back from a concussion for some reason. We don't really know. Perhaps they've got they're not as conditioned as they were. Perhaps they lack the dexterity. Perhaps they lack the confidence. There's a real risk of further musculoskeletal injuries.
Maybe just to add into that, although they are rare, as Adam was saying, Ben Robinson was a teenage boy who had multiple concussions in one match and unfortunately died. So his parents were very keen to get across his story to various authorities to try to make rugby and other contact sports safer, so all sports safer, not just rugby. So although rare, that's the kind of thing we would definitely want to obviously kind of look at and reduce the chances of. And on the long-term aspect, I mean, that's Adam will be very acutely aware of. It's the return to play mechanisms that you have in place. So after a concussion, there is a period of time, or a mild brain injury. There's a period of time where you might be feeling foggy in the head and feeling lacking concentration, and these symptoms might get worse if you start to be active and so on. But it's really important to go through a process of what we call graduated return to play. So in other words, that you start to increase your tolerance of being able to do the kind of things you used to do before. If you don't do that, then you could be left kind of getting more stressed and anxious, and that can then turn in on itself and create even more problems for you. So there is that in the mainstay, people tend to recover after a mild TBI. They tend to, that's it, 95% plus, it's recover. And it's the process of enabling the best kind of recovery so you can go back to your main activities, like contact sports and so on. Well, it's even more than 95% plus. I mean, it's especially when the acute injury does not have much of a loss of consciousness or much of what we call post-traumatic amnesia, which is a loss of consistent memory of what's going on. You may be alert and able to see what's going on, but you can't put those memories together. So Adam will have seen players where they will have, carried on in a match because the concussion wasn't picked up, and at the end of the match, they can know what the hell happened today, sort of thing. They just don't really remember the plays they had, all the rest of it. So PTA, loss of consciousness, those kind of things can give you an idea of the severity of the injury. But on the whole, people recover. But it's enhancing that recovery. But you don't want people to kind of suffer in a kind of a silence in a darkened room for ages, and then they just get into more and more worry. And then that worry then turns into problem. I guess, Adam, you've seen a lot of that in terms of both the medical and psychological management of players after concussion.
Yeah, I don't know whether you wanted to drift into talking more about the sort of treatment side of concussion in terms of how we rehab those players and get them back to full.
Probably a good idea. Yeah, because you've got a pretty good system set up.
That was going to be my next question. How do you treat people aside from just stopping them from playing for a while?
Yeah, so I think it's fair to say that there's no true consensus across the board about exactly how concussions should be managed, but there tends to be common themes wherever you are and whatever your sport is. It's certainly not like sustaining musculoskeletal injury where the protocols and timescales are fairly clear cut. So if you break your arm, we know you're going to go into plaster, and we know you'll be back in action in 6 to 12 weeks, depending on exactly what you've done. So it's really important from the outset that people understand that when they have a concussive injury, that those timescales and the protocols aren't as clear cut. The most important thing really in terms of management is for me is always about getting an early diagnosis. So what I found and what the evidence suggests is that any intervention is far more likely to be successful with concussion that's recognised at an early stage. It's certainly the converse is true, that if you've got established concussive symptoms, they become far more resistant to standard approaches. So what's really clear is that it's important to make that early diagnosis. So getting involved with players at an early stage and being able to intervene and to break those that cycle of symptoms before they become established. So as Hugh suggested, there's certainly the first step in terms of rehab is rest, and so there has to be a period of rest following a concussion. There are different views on how long that rest should be for, but it does form an important part of the concussion protocol. So it gives the brain an opportunity to recover from that initial insult. And really, athletes should be resting until such time that those early symptoms will settle down. And then, as Hughes alluded to, the next step is exercise, and that will take the form of some sort of graded return to normal activity. And there are different ways that can be done. So in rugby, we have the GRTP, the graded return to play, which is a protocolized return that escalates conveniently over the course of a week from light exercise through to heavier exercise, through to contact, through to play, such that if providing you're symptom free, you can go through the stages. You can have a head injury on a Saturday, and providing you're well and come through your return to play, you can be back to playing the next week. And and that seems to work reasonably well as far as we know at this stage. There are more scientific protocols, such as those that have come out of Buffalo in the United States, where they have an approach that's gated towards the heart rate. So they put athletes on a treadmill, they'll exercise them to a maximum heart rate where they develop some post-concussive symptoms, and then we'll set them a program that will exercise them at a fraction, so something like 80% of the maximum heart rate. So they're just sort of working below the threshold.
Yeah.
And I think, for me, early exercise is really important. Again, as Hugh has said, that the longer you leave athletes without exercise, the more they'll decondition, the more they'll dwell on the symptoms, and the more those symptoms will become ingrained. So when I'm managing players with concussion, it's really important to start some form of exercise early. And that doesn't mean they're going to be back scrummaging or tackling within 48 hours, but it does mean they can do some light exercise whereby they're ticking over, they're keeping their heart rate up, they're keeping their base fitness. Because the danger otherwise is that they just lose condition really rapidly, and particularly with young athletes who are exercising the whole time. If you were to give them 2, 3, 4 weeks no exercise, they'll find themselves in a position that they've not been in before, where they're less fit than they've ever been. And then they try to return to normal function, and they become unwell doing that, and they start to get negative thoughts about why they're getting those symptoms. And the other thing is the value of positive reassurance. So the vast majority of athletes who get concussed will recover without sequelae. And I think it's important that everyone is aware of that. So there are negative things written in the media about concussion. I think people are incredibly anxious about it. But for most, the implications, as far as we understand it at this stage, there's no evidence to suggest that there is going to be a significant adverse outcome, and people need to know that they will almost certainly make a full and uneventful recovery. That's really important. I tend to often use the analogy with recovery of thinking of the brain like a muscle. So if you pull a muscle, how do you manage it? Well, what you do is you'll rest for 24 to 48 hours, but after that you need to get blood flow back and do some training. So it's the same for the brain. After a significant concussion, you rest for 24, 48 hours, and then you're going to exercise your brain, and that might be with sort of brain exercises, so just doing things like reading or watching television will stimulate your brain, or it might be through a combination of cognitive load and physical load, putting you through to a place where you can actually train and exercise without the onset of symptoms. I think the final thing to say for me is that it's really important, and this is what I said from the outset, that care has to be individualized. With concussion, one size doesn't fit all. People react in different ways. But it's important to respond to the athlete's symptoms, so you manage them accordingly. And the majority can be managed by a standardised graded return to play, but some need modifications, and it's important to be aware of that.
I just wanted to move on to those reports, really. That it's been in the news, like you say, that reports that head trauma has gone on to cause dementia, sometimes very early on, people in their sort of 40s and 50s. So what evidence is there around, how much a brain injury can increase this risk of dementia, or is it still very, very early days at the moment?
Well, in general, a head injury or a traumatic brain injury of any kind is associated with an increased risk of dementia in general. So that there is traumatic brain injury as a condition is the biggest cause of death and disability worldwide for anybody up to age 40. So it's a major issue, from road accidents and assault and falls and sports injuries. Sports injuries are the mildest form of mild brain injury, effectively, and also we have a huge focus on it, and so the management of it, as Adam was just describing, is very, very good. They're in some parts, or improving in some ways, and sometimes not so great. The difference in sports and so on. So brain injury is a very problematic health condition in general. There is an association with dementia in general. But not necessarily in the way that people may think that there's a massive increased risk. So the thinking that it leads to a progressive dementing condition known as chronic traumatic encephalopathy is problematic. This is a condition, CTE, which has been suggested to be a common occurrence in American football players, and it's interesting research. And of course, in the 1920s and 30s, we had the idea of punch-drunk syndrome, which is effectively where the ideas come from. Chronic traumatic encephalopathy. It goes back to work in the UK, actually. And so repeated blows to the head leading to changes in brain morphology and chemistry that is associated with dementia, with increased amounts of the kind of proteins and so on that you find in Alzheimer's disease, tau pathology and such. So the idea is that there's an increased risk, but the studies in American football players by the Boston group, as they're known, is problematic because they effectively recruited a lot of American football players, a couple of hundred, post-mortem. So they as they had died, they then did they recruited them in and looked at their brains, but these are people who would have donated their brains, or their families would donated their brains, thinking that there wasn't anything to be worried about. So there was a bit of a selected sample, and there wasn't a control sample. So it wasn't surprising that there would be findings that there were some anomalies in their brains. And so the CTE story is kind of problematic in a number of ways. One, that the science wasn't particularly good from a point of view of control groups. But secondly, it causes people to really worry a lot more about mild traumatic brain injury or concussion. And we know that in the military circles, mild TBI is huge in the military. It's the biggest casualty of American forces in the Mideast wars. And people have ended up becoming depressed and anxious and suicidal over worry that they'll now to dementia. It's just the science is definitely not that straightforward. But there is a risk, and in some individuals will be a little bit more at risk than others. As Adam was saying, if there's different individual factors, maybe genetic risk factors, for some people to have a heightened response to a concussive blow than others, and therefore that might lead them to go on a different trajectory. So it's a bit of a complex story, but it certainly isn't as straightforward as there you go, you're going to develop dementia. It just isn't like that.
As a clinician working in an emergency department and pitch side, I know of no evidence that there is adverse outcome from repeated head injuries. And that might emerge in due course, but certainly as it stands, the evidence is fairly limited and certainly is far from being robust. And so I think for me, my personal view would be any suggestion that there's a conspiracy theory behind World Rugby hiding information, or that they know things that should change the way patients are management, just isn't true. As a clinician, that evidence is weak. And I think from a rugby perspective, as it stands, we're doing pretty much everything we can within reason to manage these players accordingly and safely.
Brilliant. Thank you.
So just add in that context, I mean, there are two sets of studies. I also work in criminal justice systems and the effects of brain injury on developing brains. And what we tend to find in large-scale studies in teenagers is that if they have injuries that are sustained in sports, then they don't tend to get too affected in terms of their educational outcomes or behavior or anything like that. If they have a mild brain injury in a car accident or an assault, so that's multiple hits to the head and and so on and so forth, then it's more likely they'll go on to have problems within a year post those injuries. So it's to do with the severity, the rotational kind of injuries to the brain through the head being affected, and so there's a greater severity of injury. So these are relatively mild forms. So when you have some cases where there's lingering symptoms over a period of time, it could be that was more than just a mild concussive blow. And also it could be that there's a psychological overlay that Adam has sort of explained. And another set of important studies, and where there's been control groups, there's been a study of Scottish professional rugby players where they have looked at the retired players, and they've looked at a control group of people same age, all the rest of it. And what they found was that there was a slight reduction in memory ability in the retired rugby players. Just a slight, not clinically significant, just a slight change. But then when they looked at, and no other cognitive differences, when they looked at the overall health, in 20% of the control group, there were cardiovascular problems. So they were starting to have the kind of issues that could lead to heart attacks and so on. In the rugby players retired, 2%.
Okay.
And what do you need for really good brain systems to be operating really well? Oxygenation. That's what you need. And so so I think there's a risk in kind of in overplaying the risk of concussive injuries, that people will not be participating in sports which are actually incredibly beneficial.
My final question was going to be, around the sort of level of trauma and how safe sport is, because obviously people could be reading the newspapers, they could even be like tuning into our little video now and be panicking about the idea of playing sport or letting their children play sport, and obviously we don't want people to be thinking like that and worrying unnecessarily. So you've covered it off a bit, but I'm assuming your views here are that people shouldn't worry about playing sport, and that's okay.
Having precautions are important. I mean, so going skiing, wear a helmet. I mean, having precautions, having someone as much as possible, like have them available at the pitch side to make sure. Listen to the medic or listen to the physio, whoever's trackside in a rugby match, a football match, to say, well, hang on, that kid needs to come off or whatever. That's important. Recover back and kind of back in. I think. The England Rugby Union brought out the Don't Be a Head case system that was really good. A public health approach towards managing head injury. That's across the board in schools. Activity is important. Playfulness is important. So it's important and a social aspect of team sports is brilliant as well. So there's a lot of benefits. So we shouldn't be too distracted by research that's not high quality, and the heading research is particularly low quality. I should add. I mean, that's a particularly low quality research that people have jumped on a particular bandwagon there, so there is a need to track and look after concussion, but there's also a need for really good research rather than opportunistically kind of geared research.
Brilliant, thank you. And Adam, I'm guessing you want people to still continue to play rugby and to come through Exeter and get to the Chiefs team.
Yeah, I mean, absolutely. I agree with, strangely agree with what Hugh says. I think everything we do in life, there's risks and benefits, and it's about weighing those up. There are risks associated with playing rugby. You might get a head injury, but also you might get a knee injury or an arm injury or some other kind of injury. And we do. I think as lawmakers and as medics, we do everything we can to make the game as safe as we possibly can. But the benefits are great. It's not just general health and fitness. There are the camaraderie and socialising other aspects of it. So I think we have to acknowledge there are some risks. There are some unknowns as well. And I think as the great thing we've seen in rugby is how much things have changed in the last decade. So from going from a position where 10-15 years ago, you could be knocked out in a game, come round and play on in that game quite legitimately, to a position now where you get a bang on the head, and even if you're knocked out, you might be removed from the field of play. So we're learning the whole time, we're modifying the whole time. And I'm sure as new evidence comes through, we'll change and modify to make the game even safer. So certainly for me, let's play on.
Brilliant. Thank you very much, both of you, for your time. Really appreciate it. And we'll be back with some more video interviews very soon.